Normal variation occurs in the components of swallowing physiology. This is not new information. Long-standing evidence supports the occurrence of normal variation in swallowing that occurs across the age spectrum and without functional consequences. This finding has been shown in studies that involve temporal, kinematic, or scored observations on MBS, Phys, and high-resolution manometry. Finally, the term normal has different meanings in the literature and is not always well or similarly defined. For example, some studies classify normal as denial of swallowing problems by non-dysphagic volunteers, scores on surveys such as the EAT-10, passing scores on swallow screening tools, and some even refer to normal as no evidence of impairment on persons who were referred for video fluoroscopy. Take, for example, MBSImP Component 6, initiation of the pharyngeal swallow. Component 6 represents the onset of the pharyngeal response to a number of sensory inputs, including bolus characteristics and movement of the tongue. It's scored based on the position of the bolus head or leading edge of the bolus at the time of the first movement of the brisk superior anterior hyoid trajectory. Normal variation occurs in the location of the bolus head at the initiation of the pharyngeal swallow. There are 5 possible scores for component 6. A 0 represents the bolus head at the posterior angle of the ramus at first hyoid excursion. A 1 represents the bolus head in the vallecula. A 2 represents bolus head at the posterior laryngeal surface of the epiglottis, and a score of 3 represents the bolus head in the piriform sinus. And of course, a 4 would be no visible initiation at any bolus location, which is never normal. With component 6 in mind, let's take a look at the following videos demonstrating the importance of looking at any component of swallowing physiology in the context of swallowing as a whole. Healthy non-dysphagic persons occasionally score a 3 on an individual component such as component 6, but in the absence of any other impaired component and without any functional or airway invasion consequences. This occurs particularly on component 6 with a larger volume liquid bolus. Variation in one isolated component in a non-dysphagic individual does not imply its lack of clinical relevance or justification for excluding that component on a swallowing assessment tool such as the MBSImP. In the video on your right, this patient scores a 3 on component 6 with the head of the bolus in the piriform sinuses at the onset of first hyoid trajectory. But now, this is a score of 3 in the context of a score of 1 on component 8, laryngeal elevation, which is our surrogate measure for early laryngeal vestibular closure via contact of the arytenoid to the epiglottic petiole, and there is significant airway invasion. This patient would score a 7 on the penetration aspiration scale because there was one at least attempt to cough or clear the material, although it was unsuccessful. Remember, the components contained on the MBSImP were included based on scientific evidence that they met the test for both validity and reliability in patients who were dysphagic.